Hello, my name is Olivia Snyder. I'm a third year medical student at the University of Iowa Carver College of Medicine. And today we're going to be talking about a psychiatry topic, as a few people had requested over the last few of these that I've done, and specifically substance use disorders. So um, if you guys have any trouble with getting the soap note or the quiz open in the chat, please let me know so that I can make sure that you have those links working properly. As always, our patient case, we're going to start off with and go through a physical exam and differential diagnosis before arriving at our assessment and plan. And then we're going to spend a good chunk of the day today talking about like the physiology and pathology of addiction and substance use disorders. So I think it'll be a really good session. Feel free to ask questions, participate, put things in the chat, or unmute yourself if you prefer to do things that way. And I like to keep things pretty relaxed. So if there's any questions that you guys have or need to go back or slow down at all to make sure that you're getting what you need for your soap note and quiz, then we can always go back or get, the things that you guys need. So we'll just keep going. Does everybody have this pulled up? Into our case. Today, we are seeing a 33-year-old female who was brought to the ER by ambulance with findings of altered mental status. And this was after she was found unresponsive in the bathroom of a bar. So this is definitely something that you see where a person is not able to provide their own history, and there's not really anybody to provide collateral history as well. So you really have to just go off of your exam findings, labs, and objective data. And if you're lucky, then you can sometimes have a patient who's already in your electronic health record and do some chart review to get some of their past medical history. But in these cases where they are altered mental status and can't really provide an account of what happened and give you that information, then it can be really challenging, but definitely not unusual. So in a patient where this is all we know, they come in, they're not really able to communicate with us. They were found in a bathroom at a bar, unresponsive. What are some things that we would want to think about in our differential diagnosis to, to include in what might have been able to cause this?
Well, I guess I would say, if she's at a bar, I'd probably say maybe alcohol poisoning,
Absolutely.
drug use too, because she was in the
Alcohol,
bathroom.
drugs, any substance really that can cause intoxication. Definitely, definitely, definitely. Just in the context as well, her social situation, she was in a bar. That unfortunately people do other, besides alcohol, other substances that are used in that kind of a setting as well. So we've also got some people suggesting stroke, head injury. Yeah, like really any neurologic etiology can cause altered mental status because it's your brain.
Yeah.
So those are great thoughts. What other systems do you guys think, if I challenge you to try to think beyond just the brain, could
I
cause
guess she could have gotten roofied. I guess other systems could be the heart.
Yeah, you and Bridget suggesting heart attack, head injury or hypoglycemia, I think is what Marlena said. So like a metabolic potentially.
Yeah.
Yeah, respiratory, if you're not getting enough oxygen, then that can cause altered mental status, hyponatremia, so like electrolyte imbalances.
Blood
You guys are really,
toxicity, maybe the liver.
yeah, liver, yeah, that's certainly, yeah, you can get like hepatic encephalopathy in people with like chronic alcohol use or chronic liver disease, where you get a buildup of like ammonia and just metabolic intermediates and byproducts that kind of aren't able to be effectively filtered out. So that's definitely, you guys are doing really well with this little challenge. This is just a short list of things that I came up with. I mean, altered mental status is something that you could write a whole book about things that can cause that. So for cardiovascular, things like syncope, that's just like fainting. And that could, somebody's found unconscious in the bathroom. Maybe they wouldn't have like a completely altered mental status after just a general episode of fainting, but that's definitely, something that you can get from a cardiovascular standpoint. and an arrhythmia, that definitely can cause you to lose consciousness and to have altered mental status. Heart attack could certainly go on this list as well. I just didn't have it on there. A lot of neurologic things that we've already talked about. So stroke, head trauma, substance use, we've already kind of all talked about those. Another thing, especially if they've got this kind of confusion or altered mental status after a period of like going down and they're not responsive, is to think of seizures or epilepsy. That's kind of a good way to tell if somebody's like fainted versus if they had a seizure, is if we call it being post-ictal, and that's where after a seizure you get this sort of state of confusion and being tired, and you just like aren't able to just get right back to where you were before. Like if you fainted, then you can kind of wake up and be aware of your surroundings and be able to kind of engage in what's going on. But after a seizure, it's not uncommon for people to not be able to do that, just because they're regaining kind of back to their baseline neurologic status. We had talked a little bit about some metabolic things like diabetes. On the flip side of diabetes, which is high blood sugars, you can also have hypoglycemia, and that can certainly cause altered mental status. Electrolyte abnormalities like hyponatremia, definitely on that list as well. And then just some other general things that are kind of more miscellaneous. Anaphylaxis, or like a shock type picture. Maybe she, I don't know, was allergic to peanuts and they had peanuts at the bar or something. I don't know. We don't know at this point. Something where she has a massive blood loss. So in a female of reproductive age, we think of maybe like an ectopic pregnancy, or like a hemodynamically unstable, like potential miscarriage or something. But you just have to kind of keep a broad differential for things. And then CNS infections like meningitis or encephalitis or things like that, that would maybe not present as acutely. You'd have more of like a lead up to it. But again, we don't have really any collateral history to go off of. So I think these are all fair things to keep ruled into our differential for the time being. So you guys did really great with that. Good work with like thinking outside the box. Okay, so we can't really talk to the patient, but luckily she is a patient in our hospital system. And so we're able to do a chart review of her electronic health record and kind of get some of her past medical history. So we see that she does have a history of opioid use disorder for the last 3 years, and has some other comorbid mental health conditions as well, including major depressive disorder and generalized anxiety disorder. So two of the most common mental health conditions that are out there. And unfortunately, it looks like she also had documentation of a prior suicide attempt when she was 17 years old. So kind of an extensive mental health history to include in this patient. And then also of note, she doesn't really have any chronic medical conditions, but does have hepatitis B virus. Hepatitis V virus, does anybody know the way that that's transmitted from person to person? Like what's the routes that you can get it from?
From sharing dirty needles.
Yes, you can absolutely get it from IV drug use, sharing needles, sexual transmission, body fluids. Yes, exactly. So there's like 5 different types of hepatitis, and some of them are more of like a GI type transmission, like a fecal oral route. But hepatitis B and hepatitis C are the ones that we think of for like shared needles, IV drug users, things like that. So potentially fits with this history of her opioid use disorder. For her family history, her father died at age 60 of alcoholic cirrhosis, which is a chronic liver, end-stage liver disease from alcohol use. So she, does have this family history of other substance use disorder in her father with alcohol, and then her mother with breast cancer at age 58. No other remarkable family history there. And for her social history, she works at a local coffee shop as a barista and is uninsured. So that's definitely another risk factor that we think of people who have lack of access to care, and that we want to have a comprehensive social history to kind of understand their context around healthcare, so we can be able to make decisions that will fit their needs as a patient. So this is our just kind of very quick and dirty chart review history that we're able to get. No really like HPI from the patient other than just what we saw them present with. So moving on to the objective portion of the note, we're going to go to the vital signs, and physical exam. So I'll just read through her vitals and then I'll have you guys point out the things that you're concerned about, okay? So her blood pressure is 102/68. Her heart rate is 52 beats per minute. Her respiratory rate is 4 breaths per minute. Her temperature is 37.3, and her Celsius and her oxygen saturation is 87%. So of those things, what are the most concerning ones that you are looking at?
I'd
Yes,
say I'm really concerned about her blood pressure. It's a bit low. I'm concerned about her oxygen rate because I think she's having difficulty breathing.
absolutely. Yeah. So like so many people in the chat right now are saying her respiratory rate is very low. She's barely breathing. Her heart rate is low, so she has bradycardic. Her blood pressure is also, it doesn't, it's, it's sometimes we call it soft blood pressure, where it's, the normal blood pressure in a normal healthy person is around 120/80. We start to get really concerned when it goes like below 90/60 is when we're going to start doing like fluid resuscitation. This patient would definitely need to get like IV fluids and pressure support, but she's still like kind of hanging on right now. And then kind of paired with that low respiratory rate, this oxygen saturation of 87% is definitely not normal, and that we'd want to get her started on some oxygen to help bring that up. So moving into the physical exam, she is a somnolent female. Somnolent is just the fancy medical term for like tired appearing and like not really rousable, agitated in bed. Her pupils are pinpoint, so they are like just really, really small circles, and they're minimally reactive to light. So when they're really, really constricted like that, if you shine a light on them, then they would get even smaller. And if they're very dilated, then when you shine a light on them, they would constrict more. So when they're already like as constricted as they can get, then they don't really react to light. For her cardiac exam, she has bradycardia with a regular rate and rhythm. For her respiratory exam, we see the severe respiratory depression, which is the low respiratory rate of 4. Her lung sounds are clear and equal though. So it's really just the rate that is concerning at this point. Her abdominal exam, she has decreased bowel sounds, but there's no other findings on the abdominal exam. And then for her extremities, we do see like tracks of needle marks on her arms with bruising. Her pulses are equal bilaterally, but she's got some cyanosis of the lips and nail beds. So that's just kind of like a bluish discoloration that you see sometimes in patients with low oxygen to suggest that they are not perfusing their tissues well with oxygen. So more support for us to think that she has like some respiratory compromise right now. And then lastly, for her neurologic exam, she is not alert or oriented to person, place, or time. She also has occasional myoclonic jerks. And that's just kind of like random like body twitching or like flexing of your extremities that is not like in a specific pattern. Like a seizure would be like really repetitive jerking motions. These are more just kind of like random that you sometimes see in patients with like a compromised neurologic status. So that's her physical exam. Highlights are really just that she's got this severe respiratory depression, and then some other findings with the pinpoint pupils, and the needle marks on her arms to maybe lead us down the road of thinking IV drug use. I wanted to also include this really important way to kind of classify people's neurologic status is the Glasgow Coma Scale, or the GCS as it's sometimes known. And it's a way that we look at 3 different criteria. So their eye opening, their verbal response, and their motor response to what's like kind of going on around them, to be able to see like how they're doing based on like a numerical assessment. So if you see down here, like a minor brain injury is 13 to 15 points, moderate would be 9 to 12, and severe brain injury would be 3 to 8. And this isn't necessarily like a permanent brain injury. Like your Glasgow Coma Scale or your GCS can really like fluctuate, like even minute to minute, hour to hour, day to day. So with our patient having a calculated GCS of 8 right now, that's not saying that it will always be an 8. That's just like based on her current condition. So remember that she has a GCS of 8. Does this make sense to you guys, like the severity? So like right now I have a GCS, like I would have 4 for eyes opening. I'm oriented and be like talking and carrying a conversation. And then if someone told me to like, okay, can you like wiggle your fingers, then I can do that. So that'd be like normal. And then you can't have a GCS of 0. It only goes down to 3, but that's basically like you don't respond to anything. Okay, so in the next steps, of course, we've got some labs and studies and things to order. Is there anything that we want to do first before, or what's the next step that we want to take? We're thinking head CT, give her oxygen. Yes, I like where Adam's going with this. So we know that, you know, she's not doing well from a respiratory standpoint. And so if you guys have ever heard of like the ABCs of trauma, the airway, breathing, circulation,
Yeah.
that's sort of like the first thing that we want to make sure that we secure before we take her for other things. So before we go and order tests, we want to actually intubate her and make sure that she has good respiratory support. So, and the general rule of thumb is if you have a GCS score of less than or greater than, grade, oh my gosh. Yeah, less than or equal to, I don't know what just happened, I'm sorry, to 8, then you want to intubate them and make sure that you secure their airway and provide respiratory support. So that's the first step that we're going to do. But then, oh yeah, sorry. And then the other thing I was going to ask you guys about this. I forgot that I added this part. But the other thing that we can do is if you've ever heard of the drug Narcan, or naloxone is the generic name, but
Yes.
it's known as Narcan pretty colloquially. And this is a drug that we give to people who we suspect an opioid overdose in, to reverse that overdose and to help get them to have a better respiratory drive. So before we even like diagnose or test for like an opiates or other drugs in her system, or like do any like urine studies or blood studies or imaging, if you suspect that a patient has an opioid use, like an opioid or opioid overdose, and once you secure their airway, then it's definitely appropriate to give naloxone or Narcan as it's known. So I wish I would have asked you guys what it was called, but too late now. It's called naloxone. But like we said before, now that we've kind of stabilized our patient and given her appropriate initial treatment, I think a head CT actually would be reasonable. I didn't include it on here just because like it's not as much treatment guiding, but in a real like emergency situation, if you didn't have any history, then I think it totally could be done. It usually isn't going to show anything for this. Like we know that she has an opioid overdose because that's kind of what this talk is, but these things would help to just kind of like confirm that. But in real life, if you're like, she may have had a trauma, she may have had like a fall or something, then I think a head CT would totally be appropriate as well. So these things are just kind of done empirically to confirm or rule out substance use induced like intoxication. So we do a urine drug screen, a urinalysis, blood alcohol concentration, and then a creatinine kinase. If you guys know what that is, it's a marker for muscle breakdown. So it's an enzyme that like, if I'm doing a bad job of explaining this, but like if you have breakdown of your muscle tissue and you release the molecule myoglobin into your bloodstream because you've like broken down your muscle, then you would have an elevated creatinine kinase. And in patients with suspected opioid overdose, you can have like a lot of muscle rigidity. And that's called rhabdomyolysis, if you've ever heard of that. And I'm kind of going down a rabbit hole, so don't worry if this is too confusing for you, but that's just one other additional lab. And I wanted to make sure I explained it instead of just like blowing over and pretending like everybody knows what that is. So this is kind of like the standard order set for of diagnosing an opioid overdose in the emergency department. But I also think a head CT would totally be reasonable to get. I just didn't include it here. So we find that her urine drug screen is positive for opiates and benzodiazepines, which, as we learned before in her chart review, she is on a benzodiazepine called alprazolam. And her blood alcohol concentration was 0. So it looks like she hasn't actually been drinking despite being found in a bar, maybe was there for other reasons. And then her urinalysis and creatinine kinase is normal to suggest that she does not have a severe enough overdose where she's having skeletal muscle breakdown and potential kidney injury. So that's why we would have checked those things, but they look normal at this point. Again, head CT, let's just say that they did scan her and it came back normal. And so we don't have to like pursue any like neurologic, like neurosurgery consult or anything to help with like any potential trauma that she could have had. Okay, so going quickly into the assessment and plan, and then we'll kind of break for questions after that. But we have a 33-year-old female with a history of major depressive disorder and generalized anxiety disorder, opioid use disorder, who is presenting with altered mental status and a severe respiratory depression. On exam, it is significant for pinpoint pupils and a GCS score of 8. So she is intubated and given naloxone on arrival for a probable opioid overdose. So our plan is to kind of continue giving her naloxone or Narcan, as I said before, which is the mechanism is a full opioid antagonist. So it will displace the opioid agonist or the actual drug that she took from the opioid receptor and help to like decrease the effects that it has on the respiratory physiology. So we're going to continue giving her naloxone despite giving that like initial resuscitation dose. You can actually give multiple doses of it until somebody's like responding. Someone's asking, can naloxone harm someone who is not overdosed from opioids? That's a great question. And the answer is no, it does not. It only is going to displace or block those receptors. So potentially the only harm would be that if they're receiving like opioid pain medicine in the hospital later on, that it might not have its full potency, but it's not going to cause any like vitals instability or like side effects to actually propagate harm. And you really do want to do this like empirically. If you suspect if you have a high index of suspicion for someone to have an opioid overdose, then you definitely don't want to hesitate to give the naloxone. That's a great question. And we'll go through a little bit of pharmacology later so you can kind of see the difference between like naloxone or the agonists and antagonists, because they can kind of be confusing. But great question. So we're going to continue giving that and then also admit her to the ICU for further observation and to make sure that she is kind of recovering from a respiratory standpoint. Okay, so a little bit of a whirlwind there. A little unusual for these cases because we don't have like a formal history, and we had kind of that little break of treatment in between the workup, but that's really how it is. You want to make sure that you're following your ABCs and making sure that if you see a patient who is not respiratory, like they do not have good respiratory status, that you take care of their breathing before you do anything else. So any questions, or do we need to go back to any slides at all for you guys? Okay. If you change your mind, then we are always able to go back later. So a little bit first about the epidemiology of opioid use disorders before we kind of get into the pathology and pharmacology of it. So the opioid use disorder criteria is outlined in the American Psychiatric Association DSM-5, which is like a book of all the different mental health diagnoses that you can have and the like criteria for diagnosing them. But the highlights are essentially that someone has a desire to obtain and take opioids despite social and professional consequences. And examples of opiates, since not everybody is like, I don't think I really would have been able to tell you what an opiate was before I was in medical school. So things like heroin, morphine, codeine, fentanyl, oxycodone. Those are all opioids. They have a basically the same like mechanism of action, and they bind the same receptor in the body, so they have the same effect. It just is a matter of their molecular structure and like how potent they are. So the difference between heroin and morphine is like almost nothing. I think one just like has an extra double bond or something, and it's like just way more potent. Heroin is way more potent than morphine, even though they have the same effect. So that's kind of the criteria or the definition. This is the actual criteria. And it does have, like all things, kind of a range of mild to severe. So if you, have these different things that are applicable to a patient and have like 6 or more checked off, then that would be criteria for a severe opioid use disorder. So things like recurrent use and a failure to fulfill major obligations at work, and it's interfering with your job. You have a tolerance or you have withdrawal symptoms. And this is all available online if you guys are curious for like the details. And don't worry about these like specific criteria, but the point basically is like, are you using the drug to the point where it's interfering with your life? If the answer is yes, then you probably have an opioid use disorder. So 2.1 million people in the US have, they meet criteria for the opioid use disorder, and 9.7 million have misused narcotic drugs at some point in their life, whether that is like prescription for actually like in their name that they've misused or like experimented with in other settings. So it certainly is prevalent. Risk factors for opioid use disorder, and really like all substance use disorders, including alcohol, benzodiazepines, those sorts of things. So it's a combination of social, environmental, and genetic or biologic factors that kind of all come together and put people at either higher or lower risk. So the risk factors that put you at higher risk would be things like comorbid psychiatric illnesses. So like in this patient, she had a history of depression and anxiety and a prior suicide attempt. So the presence of those things are definitely like negative prognostic factors for opioid use disorder. Polypharmacy, which is essentially just the fancy name for being on a lot of medication, especially if you're taking like benzodiazepines and antidepressants, which our patient was taking both of those. But we see this risk increased in people even with a lot of medical comorbidities, and they're just on a lot of medications for their health. And maybe they have, like chronic pain. For some reason, they're on like chronic opioids. And Marlena's asking if opiates and narcotics are the same thing, and that is true. Yes, they are narcotics. Opioids is like just a more specific name for the drug class, and narcotics I think is probably more from like a legal standpoint. That I don't actually know like the difference in terminology, but they do refer to the same drugs. So yeah, thank you for asking. Positive family history. So in this case, a father with alcohol use disorder, and so it doesn't have to even be the same substance, but just a history of dependency on a substance in a immediate family member can certainly increase your risk of other substance use disorders or the same substance. So we really do see, like, especially alcoholism tends to really run in families, and it can be really hard for patients to kind of break that cycle. Unemployment, homelessness, lack of social support and other protective factors. It also, I didn't include this on the list, but I did want to mention that just accessibility to the substance. So if something is just like freely available and sitting in front of you and like there's no restriction to you getting it, then people are more likely to engage in that behavior. Whereas if things are really kind of like on lockdown, or if it's illegal and there's legislation to, prevent the use of those drugs, or people just aren't around it, then they're not going to seek out and engage as much in those behaviors. So that'd be like one protective factor, in addition to like the opposite of all these things being protective. So people without a positive family history, people who have jobs or who have homes and families who are supportive and they have access to care for their other mental health conditions, those would all be things that are protective factors for substance use disorders. So now getting a little bit into the pathology of addiction, I have this figure here kind of showing how opioids affect the brain. We do naturally have opioid receptors in our CNS, and they normally bind things called endorphins, which, like if you've ever heard of a runner's high where you exercise and get like a, that you're just like naturally releasing endorphins to help with the pain in your body, and it will bind your opioid receptors in the brain. Of course, at like a much lower level than you would if you had a synthetic drug, but it does kind of activate that same pathway. And so these receptors are already present in our bodies. And so when we give extra of the opioid, or we give a more potent version, like morphine or heroin, compared to the endorphins, which are like very not high potency, then you get stimulation of the dopamine reward system. So that's, I'll go through the dopamine reward system in a second, but the physiologic effects of opioids are that they're CNS depressants. So we kind of split certain drugs into like being a stimulant or a depressant. So stimulants would be things like methamphetamines, cocaine, caffeine, nicotine, for example, those ones. And then depressants would be things like opiates, barbiturates, benzodiazepines, alcohol. Those are the ones on the top of my head. So we kind of split those into two different camps. CNS depressants are going to be activating the parasympathetic nervous system. So we drop our respiratory rate and drop our respiratory drive. Pupils get constricted and our GI tract is slowed down. So I kind of think of like your parasympathetic system as being the opposite of like if you're being chased by a bear, where like if your sympathetic nervous system is activated, then like your heart rate's going to be going really fast, you're breathing faster, your eyes are going to be dilated so you have better vision, you get that sort of like crampy abdominal pain, like, oh my gosh, I'm in trouble, like I get, the nervous stomach cramps and stuff. So your GI tract and like everything is just kind of like sped up to try to enhance your fight or flight response. And so this is kind of the opposite of that. This is the dopamine reward pathway. I think the figure is way more confusing than it has to be, but this is probably the best one that I found online. So really, I just want you guys to be able to see that in the top half here, this NAC, that stands for the nucleus accumbens, and that's a section in the brain that releases dopamine. And so when we have things that increase the reward pathway, or a trigger that we would associate with something that increases the reward pathway. So this can be anything like gambling, drugs, sex, food, anything that really causes like a sense of reward or motivation to seek can activate this pathway. So we get release of dopamine from the nucleus accumbens in the brain, and that reinforces a association with that trigger to like continue seeking it, because we'll want to continue getting that dopamine, if that makes sense. Let me see what else I wrote here. Oh, sorry. So maybe like in a patient if they have like opioid use disorder, maybe they are at a party and they just see other people engaging in it, even though they themselves haven't engaged in that behavior, then they can already start to activate this pathway. Adam's asking, is this the mesolimbic pathway? That sounds right to me, and I really should know this, but I just took like all of my step exams this like past couple of months, and so my brain's in like a detox right now. I can look that up for you and confirm whether or not that is true, but I want to say that is correct. There's like 4 different dopamine pathways in the brain, one being like motor function, which is not I think, yeah, this is the mesolimbic. I'm so sorry for not having a better answer there, but I can double check for you. Okay, so yeah, you probably actually know better than I do at this point in time. So thank you for giving that clarification. Okay, so any other questions right now before I'm gonna kind of continue going through? I just wanted to take a break and see if the pace is okay for you guys, if you need to have us slow down, or I can speed it up if we need to. Everything going okay? Okay, cool. So for a patient update, on day 2 of her admission, she starts experiencing body aches, loose stools, and sweating. So what would be something that we think could cause these symptoms for her given her clinical context?
I think withdrawal. She's in withdrawal.
Absolutely, yeah. So these are like very classic opiate withdrawal symptoms, which is, I mean, really like withdrawal from anything is just going to be the opposite of whatever it does to you. So if it causes constipation, you're going to get diarrhea. If it causes euphoria and like a high feeling, then you're going to get like pain and discomfort and anxiety. Weird other things, you can also get like sweating, but also goosebumps at the same time, and your eyes will be more dilated than they were before. So people are like extra sensitive to light and can get headaches. And it certainly does not look like a pleasant experience. So for the pathology of withdrawal, you know, we just talked about kind of how it's the opposite of what it does to you when you have that stimulus there. And I think this graph does a good job of showing what happens over time. So at the beginning of the graph here, like in a person who's naive to whatever the substance is that they're using, at their baseline, they're already doing, fairly well. And so when they get that drug, then it makes them experience the high, and then they come down from it and they just kind of go back to their baseline. So it's not, you don't really get withdrawal if you're like a first time user, but as you continue to use over time, then like the effect of it on your baseline function is less and less and less with the same dose. So tolerance is defined as the increased requirement to produce the same like euphoric effect. So think of somebody who's like maybe a really heavy drinker, and they can drink like, I mean, gosh, I see people who drink like a handle of vodka a day. And like, that's just to get them to feel normal and not even to make them feel drunk. And for a lot of people, if they drank even like a tenth of that, then they would be like literally dead because their tolerance is not that high. So tolerance is the increased dosage requirement to produce the euphoric effect, whereas dependence is you keep dipping lower and lower each time under this baseline feeling where you feel even worse than you did before. So you have these like kind of withdrawal symptoms that you have to kind of play catch up with, in like you use whatever substance to get you back to that baseline. So at a certain point, people don't even really experience the high or the euphoria as much from the drug use as they are just trying to get back to their normal functioning, because their body is so used to the drug that it feels terrible without it. Adam is saying that he read a paper on how drug use first starts as a positive reinforcement mechanism, and the more that the substance is used, it turns into negative reinforcement. And that is absolutely true. So like people chase it initially, like that high and that fun feeling. I've never used opiates before, so like I don't know what it's like, but like there's obviously they're highly addictive substances and people are wanting to use them for a reason. But then as time goes on, they really just become locked in that like the prison and the cycle of having to use them, because without like that negative reinforcement, if you take it away, then it like they just cannot function. So that's the difference between tolerance and dependence. Withdrawal symptoms, we kind of went through these. They do peak around 72 hours after the last use. So they can, obviously onset before that and maybe linger a little bit longer. But the worst of it's usually like a few days after your last use. And we talked about the symptoms. They're essentially the opposite of the intoxication symptoms. So flu-like symptoms, chills, body aches, diarrhea, sweating, dilated pupils, goosebumps. And despite appearing to be very, very uncomfortable, and patients can have extremely bad anxiety during these periods too, these are not life-threatening. Withdrawal from opioids is not life-threatening. So unlike in alcohol, if you're a heavy drinker and you stop cold turkey, you can actually have life-threatening complications from that. And that's called delirium tremens. And it's where you can even have things like seizures because your body is in such a state of withdrawal. Same with benzodiazepines. If you stop taking those, then you can have like pretty like significant and life-threatening withdrawal symptoms. So those we do need to treat prophylactically with, you can actually in some hospitals, like in a patient with alcohol use disorder who's going through alcohol withdrawal, you can order alcohol like as a medication in their system to help like, you know, give them some relief from that. But usually what we do is we have other medications to like lessen the effects and to protect them from things like seizures that would be life-threatening. And yeah, like so I said, for opioids, we don't have to do that. It's just kind of getting them through this period of withdrawal and helping them feel comfortable and supported. So like keeping the room dark, making sure they stay hydrated, maybe helping like to give like an anti-diarrhea medication, temperature control, those sorts of things. So yeah, well, I've never personally had to take care of somebody who is going through opioid withdrawal, but it sounds pretty terrible. So once the patient is stable and ready for discharge, of course, we don't want to just send them home after they just had a almost like life-threatening overdose and with a history of their substance use disorder. We want to really support them in their journey to sobriety and to recovery from their disorder. So we want to make sure that they're following with a psychiatrist or a substance use specialist. There are certainly resources in the community for people who are uninsured or underinsured who have these barriers to their care, and it really depends on where you're from. So in Iowa here, we have like a free mental health clinic that that treats people with, you know, all sorts of conditions. And then we have like multiple different tracks in the hospital, ranging from inpatient to partial hospital to outpatient treatment for their substance use disorders as well. So really there is such a variety in what is available depending on your geographic location and what you have access to. But we definitely want to get them in touch with a psychiatrist or substance use specialist, encourage them to have cognitive behavioral therapy, and also provide medication assisted treatment. And I'll go through those in a second. But essentially that's providing them with a either partial agonist of the opioid receptor to make their withdrawal symptoms and their cravings not as strong, but like not contributing to their addiction and to their like feelings of euphoria or feeling high or things like that. So I'll go through that in the next slide. Certainly some people do need to have like an inpatient recovery or rehab. There's multiple different avenues for that. You can do it in a hospital. You can do it in like a group home. There's a lot of different things out there. Narcotics Anonymous is another resource for people who maybe are doing it more like on an outpatient basis or trying to maintain after they've achieved sobriety. And it is a free resource that's available like so many places. And I don't think people know about it as much as Alcoholics Anonymous, but it's essentially the same thing for people who have opioid use disorder. Some of these medications that I talked about a few minutes ago in the medication assisted treatment are called naltrexone, buprenorphine, and methadone. And they're all essentially have similar functions for the purposes of this chat. They're gonna just somehow block the opioid receptor in a way that either antagonizes it or partially agonizes it so that you don't have that effect of the actual drug, and it helps to reduce your cravings and to reduce withdrawal symptoms, but it doesn't actually cause the high from the drug. And so you can kind of see these are the molecular structures here are pretty similar. Morphine and heroin, like I said before, I don't think I'd be able to identify maybe it's this like, what is that even, a ketone? No, it's a carboxylic acid. You guys, I've been taking organic and so on, but the molecules are very similar between like morphine and heroin. And then you can even see like here in naloxone, it looks pretty similar to morphine. So that's the one that we use back for the initial overdose symptoms. And that's to help displace the morphine or the heroin from the receptor. Naltrexone's a little bit different. That's the one that we would use for maintenance treatment and medication-assisted treatment, but it still is a opioid antagonist. So going a little bit more into the medication-assisted treatment. So this is the graph that shows kind of the effect of the opioid. So the first thing that we did here, the antagonist, the naloxone, you see that the opioid effect is 0. It's just on this x-axis because it's not actually activating the opioid receptors. A partial agonist like buprenorphine is going to have like more of a blunted effect. So it can help people with not feeling as strongly, like not feel as strong of withdrawal symptoms and of cravings, but still a little bit engaging that compared to the naloxone. And then you can also have full agonists like methadone that can be used in people with like more refractory to the other things. So like we talked about the mechanism for these medications, they reduce cravings, treat withdrawals. They do block subsequent drugs and prevent overdoses, and they can help patients return to normal functionings. Some common misconceptions about medication-assisted treatment: medications do not just get patients high, they do not impair functioning, and they do not just exchange like dependence or tolerance for one drug to another. These are highly effective medicines with great patient safety to try to help them achieve remission from their disorder. And then this picture just kind of shows again like how the differences in binding with the opioid receptor. So like naltrexone is just going to completely block it. Buprenorphine is going to kind of engage partially. And then methadone is going to kind of fully bind the receptor. So I know that's kind of a lot of treatment information that I just threw at you guys. Any questions about the pharmacology there before we move on to the next thing? How do they decide which medicine to give? That's an excellent question. And I don't even know if I know that off the top of my head. It probably depends on your insurance status, access to like what you're able to. So like for methadone specifically, I know you have to like go and get very regular appointments and have it filled very frequently because you can't just like take a bunch of it home. They want to make sure that you are you know, like still trying to have recovery and make progress. Naltrexone can also be used for alcohol use disorder, interestingly. It can help with reducing cravings for that as well. So I think it just kind of depends on like what comorbidities you have. Like if you also have an alcohol use disorder on top of your opioid use disorder, then naltrexone would be a great option for you. If you're somebody who can't go to like your methadone clinic as frequently as you would need to, then maybe buprenorphine would be a better drug. But I honestly don't know if they choose based on severity alone. I think it's probably a combination of factors. And then I hope that answered, is it Ticia? I apologize if I'm mispronouncing your name, but so with the abusing other substances, like the naltrexone can be used for alcohol disorder. If you have like a amphetamine use disorder like meth or other like synthetic amphetamine stimulants, then these would not work for those because they are activating different receptors in the brain. And there's kind of a common pathway between the alcohol and the opioid receptors, but it's just a little bit different. Don't get too worried about the pharmacology of like how naltrexone works, but these ones would be used primarily for opioid use disorder, and then with the exception of naltrexone, can be used for both. So good questions. I'm not a substance use expert or psychiatrist myself, so I don't know the specifics here. I just am a strong advocate for people having access to the care that will help them have the best chance at recovery. And I think there's a lot of stigma around getting these types of medications because people think that it's just going to replace what they're addicted to, and that just isn't true. They can be a really key part in patients achieving remission from their addiction. I also wanted to plug harm reduction. If you guys have ever heard of this term before, it can be used in a lot of different things, from like sex ed to wearing seatbelts, wearing, I don't know, like just so many different things. And being that I'm from Iowa, we have something called the Iowa Harm Reduction Coalition. And these are just a couple of strategies that this organization has implemented to help with drug users in our community to try to reduce the complications and adverse effects of the behaviors that they engage in. So one thing that I think like people are really confused about is like one program we have is a clean syringe exchange program. So people who use IV drugs are able to get access to clean and unused needles for their injection, rather than relying on like a used one or a dirty needle. And at first, when I heard that, like however many years ago, I was just thinking like, well, isn't that just encouraging their drug use? Which it seems like it could at first glance, but really like harm reduction strategies are not solely focused on just completely stopping the drug use, but ultimately, like we would love to see that happen. But for people who are going to continue using anyways, we want to make it as safe as possible. So like fentanyl test strips in whatever the drug that they're going to be using to see if there's any like contamination that could cause an overdose. The syringe exchange program, providing naloxone kits to patients or their families, or even like places like bars or concerts who would maybe have these in the bathroom accessible for people to use if they were to overdose. And then like HIV and hepatitis testing for people to learn about their status and help like reduce rates of transmission of those infections through the community. So these are just like some strategies that I think are like they're really, really important, and a lot of misunderstanding around because it seems, I think at first glance, like enabling, but you just have to remember that like if the alternative is people doing these behaviors that are harmful in ways that are even more harmful than what we could potentially intervene on. So if you are potentially saving a person who's using IV drugs from getting HIV infection, then that would be like a worthwhile effect of harm reduction. So just a little plug there for that. I also wanted to include a little about psych slide because you guys tend to really enjoy these, learning about the specialty that we talk about today. So psychiatrists diagnose and treat a range of mental illnesses, including depression, anxiety, schizophrenia, bipolar disorder, personality disorders, eating disorders, substance use, behavioral and developmental disorders. And they can work in a wide range of practice settings, including clinic and inpatient settings, the emergency room, crisis stabilization, and you can even still do procedures. Like if anyone's ever heard of electroconvulsive therapy, it is a treatment that is still used. It sounds really old, like maybe a little bit medieval, but it's actually a highly effective treatment for refractory depression or schizophrenia, people who like need immediate results if they're in a depressive episode, if they have like catatonia, things like that, where they just cannot wait for like a medication to work. You can induce a seizure and under anesthesia and do that a few times a week. And it's actually really effective at getting people into remission with those. So you can still do procedures as a psychiatrist. Like all medical specialties, you do your 4 years of medical school as in either MD or DO. And then psychiatry residency is like a 3 to 4 year, I think it depends on the institution or the program. And you can do fellowships for psychiatry and work exclusively with children or adolescents, work with patients with addiction medicine, geriatrics, forensic psychiatry, or like be an expert witness in a court. I think like kind of the big one in the news recently is like the Johnny Depp trial, and they have a psychiatrist who like is talking about the other person like having personality disorder. So they like have, you know, their expert opinion there. Interventional psychiatry, like this electroconvulsive therapy or ECT, and then neuropsychiatry. So working with patients who might have like dementias or neurodegenerative diseases. So that's a little bit about psych. I personally am not going to be going into psychiatry, but I have friends who are. They're a really awesome group of people. And if you're passionate about mental health, then this might be a good field for you. These are my sources, and it's about that time for us to wrap up the talk, and you guys are free to start working on that quiz, and I'm happy to go back to any slides to help you out with any of the questions. And yeah, any other questions that you might have about either substance use or psychiatry or medical school in general, I'm happy to help with. But thank you guys all so much for coming, and it was great to have you tonight. Anything I can help with right now? Usually what I do is I just kind of hang out until most people have logged off the meeting. So feel free to go if you have somewhere else to be, but I like to stay around in case people are working on the quiz and have any questions come up, or if you randomly think of a question about like medical school or applications or anything like that. So, and I think if you've come to any of my previous virtual rounds, I've probably mentioned before, but I'm planning on going into anesthesiology. So if you have any questions about anesthesia or specialty choice as well, then I'm happy to talk about that. Also can confirm that the reward pathway is officially known as the mesolimbic pathway. At one point in my life, if I, like in my second year of med school, I would have thought it was crazy that I didn't know this right now. But like I said, my brain is a little bit, coming off of a long few months. So I'm currently working on letting go of a lot of the extreme details that I've had to learn for step 1 and step 2. I think it was Adam who asked that. So if he's still on, you were right. All right, well, it looks like it's just the 3 of us left. If you guys have any questions, now Emily. So thank you. Hope you guys have a great night. And I think I'll probably end the meeting unless you have any questions right now, but thank you so much for joining us.